psychologist from, I think, Rice University. She's in Texas. I think it's at Rice. And she's written several books. One of the main bestsellers is this one mentioned here called Daring Greatly, how to have the courage to be vulnerable, how the courage to be vulnerable transforms the way we live, love, parent, and lead. And you can read the quote, but I'm going to tell a story while you read the quote that she has told that is so poignant. And this says a lot about how we need to think about how the men we are either sharing our lives with, care about, or treating as patients view seeking help. So she talks about how she was doing a book signing for this book. And forgive me if you've heard me tell this story, because I tell it a lot because it's so poignant. She talks about how she was doing a book signing and there's a woman there with her like late teen daughter and her husband. And after the book signing, the daughter and the woman come up to get their book signed, and they're big fans because she writes all about women and shame and vulnerability, right? And she writes about how sharing and being vulnerable is an antidote for shame. So then they go to leave, and the husband slash father, it says, I want to go talk to Dr. Brown. And they said, no, you just came to be with us. You don't really have anything to talk to her about. And he said, no, I'm in line. I want to talk to Dr. Brown. And they were like, oh, what's he going to say? So he gets up to the front of the line, and she's used to all these adoring fans. And he says, so why is it that you only write about women and your whole notions of shame and vulnerability? And she says, well, that's, what I've studied, and that's what I've written about, because that's what I know. And they prove the point of sharing your vulnerability as antidote to shame. And he says, well, isn't that convenient? And again, she's used to adoring fans, not being confronted. And she says, well, what do you mean? And he says, because your hypothesis doesn't really fit with men at all. And this was, years ago after her first book came out. Since then, she's done a little more research into men. And she asked him, what do you mean by that? He said, you talk about how sharing vulnerability is the antidote to shame. So my wife and my daughter here tell me, Daddy, honey, talk about what's on your mind. Talk about what's concerning to you. It'll help you feel better. It'll help you not feel shame. And he said, the only way I can describe on the look on their face when I share anything that I'm feeling shameful about is one of disgust. He said, they'd rather see me die on my white horse than fall off of it. And studies show this, that other men and women emphasize these stereotypical ideals of men never showing weakness. For women, a lot of their shame is around not being able to achieve the multitude of things we expect women to achieve that are impossible to achieve, and that they're supposed to be great at everything from parenthood to partnerhood to work and career and sports and everything. And it's impossible. And that's what a lot of women feel shame about. For men, it's about being perceived as weak. And it's evolutionary, right? Because men or males in many species can't be perceived as weak, or they will be attacked and shunned from the tribe. So this idea of showing your vulnerability by sharing, by going to a practitioner and saying that you have a problem, especially if it's an emotional, psychological, social problem, is something that's very hard for men to do. And we need to recognize that and figure out, how do we not make them see a look of disgust on our face and not make them feel shameful about that. The other person that's written about that, and I just want to see if there are any comments actually before I jump to that. How do I get back to that? Let's see. Okay, is Peggy Ornstein. So raise your hand. Can I see your hand? How do I see hand raised? If you've read this book, Boys and Sex. Oh wait, I skipped a slide. Oh no, I put the slide out of order. Don't look at that slide yet. Look at the slide. There you go. All right. I don't know how I see hands raised, but try raise your hands if anyone's seen this book, Boys and Sex by Peggy Ornstein. So if you haven't, and you treat men, if you have men in your life, especially if you have a teenager at home, you have got to get this book. And if you don't have the time to read the book, read the Atlantic magazine article that came out maybe 3 months or so that kind of talks about it, an interview with her, and has a really good summary of this book. She had written a book, Girls and Sex, previously. And then she wrote this. And in this book, she interviews boys who are like late teens, early 20s, basically late high school, early college age boys. And it is so, to me, shocking as a father of a teenager, boy and girl, I have twins, as well as really eye-opening. And it helps you understand, especially if you see teens in your practice, what guys are going through. Again, we know it's really hard to be a girl and a woman in this society. It's really hard to be a teenage girl with social media and expectations. And like I just said, all the expectations we place on women in our society that are impossible to achieve. but it's also really hard to be a boy and a man in our society right now. Besides this, what we just talked about the whole John Wayne ideal not serving men well, it's also about actual sexual behavior. And that's not just intercourse sex, but sexual, everything around sexual behavior that with other boys or with girls that boys are going through right now, that it's exposed in this book. And she talks about how these boys she interviewed really opened up to her and talked about how scared they are to engage in sex, how much pressure there is, how their partner is going to post on Instagram how long they lasted. And so they have to last a long time. And they are all having exposure to porn. And that completely warps what they think their performance should be about, what they think their partner wants, what kind of role they should be playing. I don't think I could go through it at this age that they're all going through it. So it's important for us to have insight, again, especially if you have teenagers in your life as patients or as family members, to understand how confusing a time it is. And it was really struck me, it was one, like, I think it was like an 18-year-old senior in high school said, when I am engaging in sexual behavior, I'm so not present. I'm not connecting at all with my partner. I'm more worried about, what does she think of me? How am I performing? What's she going to say to her friends? What's she going to post on Instagram? How long am I lasting? I'm looking at the clock to make sure that I don't ejaculate before 7 minutes, because 7 minutes is the time that if you ejaculate before that, then they make fun of you and you'll be shamed. Again, that whole idea of shame. So really important to look at some of these leaders in the field who have written about this, and there are more, but I think these are some really good sources to understand what's going on right now in terms of masculinity and manhood, and helping our patients feel comfortable talking about some of these issues so they'll come to us, because a lot of guys, like I said, aren't, and we're not opening up our practices in ways that they know they can talk about these things. Looking at Q&A, any questions anybody have, or any comments, any experience with these? All right, Lena wrote a comment. Yep.
Great. Yeah, if you want to read the comment, that'd be great.
Sure. Lena, I hope it's okay if I read this. Thinking about what that man said at the book signing, thanks. I was thinking the reverse might be true for how, and I'm totally generalizing, a woman showing strength, assertiveness, speaking without question marks can be looked at funny by certain men in certain situations. It's really just about boxes, as you said, and how we look at people that don't fit into them. Absolutely. Absolutely. I mean, we don't need to get all political, although Kamala, yay, but look at women running for office and how women sometimes themselves don't vote for women running for office because they see them as too powerful, as being too assertive, yet we want our leaders to be assertive and powerful. Yeah, we men are the worst with men, women are the worst with women. We put ourselves in these, very difficult situations, and we judge each other really harshly. So I think it's a really good point. It absolutely applies to women and to men as well.
Myles, I just really want to thank you for this honest discussion, because I feel like, I have young kids who are 9 and 11. And while we're not to this type of obviously conversation yet, you can already see these boxes that they get put in, and without real dialogue around how we want to redefine women and men for kind of the future generations, we won't get there.
Right.
It's not like kids are just going to out of nowhere figure this out. And this is so critical to, just when you think about integrative health, we're really talking about a holistic approach to our own person. Yes. And being able to navigate what that means in today's day and age, and on top of everything else. I think about how hard it was for me as a young person, and now with social media and all the additional pressure, I don't know how kids are managing it. So I really love that we're talking about this, and that, I think this is a huge space that we as integrative providers could think about moving into. And I love that you're helping to lead this conversation.
Thanks. Yeah, I think it's really important, because we talk a lot about gender identity, gender issues, but those are not as important as what we as society ascribe to the different genders. And so in a way, it's really about, regardless of what gender someone identifies as, it's what expectations are we putting on them? And how do we make sure that they're free to just be who they are? And then the gender decision and the gender issue can be a different thing, but it's really about, let's try to take gender out of it as much as possible and just help our patients understand that there are, for humans, they need to share. Humans need to share vulnerability. Humans need to not feel like they have to take care of everything themselves. So thanks. So I'll just say in the link to T, because I know a lot of people want some real practical help with that, that there historically had been thinking that testosterone was responsible for toxic masculinity, and really it isn't. So what's interesting though is a lot of those studies that were older that you might have seen even in whatever professional school you went to, that like studies showed that there's more likely to have high T among criminals who were aggressive and doing some kind of criminal act. Those studies have been pretty much shown to not be really well done, and that isn't really true, that there's higher average testosterone among aggressive criminals or violent actors. But there is evidence that higher T correlates basically with what society perceives as masculinity. So this is a really good study I pointed to here for you to look at about that, because they did an interesting way that I don't want to get into because I want to get into testosterone, but it's really well done to show that really what testosterone increases is manliness, and whatever that idea of manliness is. So in this study, it was just as much about being selfless, because that was seen as manly, as it was about being aggressive, because aggressive is also seen as manly. So again, think about evolutionarily. Your reproductive hormones are going to accentuate whatever you feel that sex hormone is supposed to help you achieve in that gender that you are living as. So if you feel, or your brain, your primal brain feels men have to be aggressive, then T will make you more aggressive. If you feel men need to be nurturing, then T will make you more nurturing. So just realize T doesn't make people aggressive. And they've even shown that giving T doesn't cause aggression. So let's jump into T a little bit though. And again, this is like something that I feel really strongly about. One quick thing. Ira Goodman he just released a book on Amazon entitled Lion Dad: How to Nudge Your Cub into an Elite College, including the Ivy League, and Enter to the Tiger Mother, writing under the pen name J.K. Rourke, MD. Male perspective, awesome. Yes, it's not just about Tiger Mom, so that's great. Thanks, Ira. So low T is a big issue, and a lot of us integrated medicine docs kind of don't check T. We talk about libido. We may help with libido. We may help with some of the symptoms of low T, but I'm going to talk about today why it's important to really assess actual T, because low T contributes to a lot of things besides the symptoms, but actually a lot of risks for early mortality, cardiovascular disease, metabolic syndrome. So it's important to really, if you're going to treat men, to really think about checking T and working on that in a bunch of different ways. We know that it's a very prevalent problem. Hypogonadism affects 30% of men. That's about a third of men over the age of 40. It's a gradual decline, I'll show you in the next slide, over time. And these are the main symptoms. And I know you know this, but again, we always hear about ED, we hear about libido, but fatigue, cognitive function decline, moodiness, irritability, decreased muscle mass, increased body fat, and decreased bone mineral density, which you probably wouldn't pick up on if you didn't do a measure, but if somebody gets a lot of fractures that they shouldn't get, something to think about. So these are the main symptoms. It does decline with age. So the causes are really age, and age, which I'll show you in a minute. There are other hormones to consider, and as integrated medicine practitioners, we do want to check the whole milieu of hormones, because hormones by definition affect everything in the body, right? That's what a hormone is. It has receptors all over the body, especially on other hormones. And that's why I'll talk about the interplay between low testosterone and metabolic syndrome, because insulin and testosterone are linked. But it's important to look at all the hormones. I'm not going to get into all these other ones right now because we only have an hour to do all this. But certainly it's something to think about if you're going to delve into it, is looking at these other hormones and using saliva, dried urine, serum, however you want to test. And that's things you can take a course on through AIHM, through other places. But with testosterone itself, it's a principal male hormone. We remember it comes from cholesterol, and that's important for various reasons to understand later. It's secreted in the testes, a tiny amount from the adrenals, but mostly it's DHEA as the male hormone from the adrenals. And it has anabolic effects as well as androgenic effects. We know all this, right? We're not talking about anabolic steroids that guys at the gym might get that are Winstrol and these other things. We're talking about plain old bioidentical hormone, testosterone. The target organs, like I said, we know hormones are hormones because they affect all different organs. It's not just a sex hormone. And men don't understand this, and female partners don't understand this. So when you say, I'm going to check your testosterone, and they're like, whoa, I'm all good there. You say, no, but you're tired and you're moody, and I see a little bit of man boob action. So they're going to think you're just saying they're having sex issues. You're explaining, no, you know what, your blood sugar is high, and I'm seeing some signs that you could have low T. So realize patients and understand that testosterone affects all these organs that are on the slide here, from the brain to the skin to the kidney to the muscle, the liver, as well as sex hormones. And remember, there's a feedback mechanism. Remember, it's the hypothalamus pituitary gonadal axis. And that's really important when you're thinking about things like fertility. And when you talk about giving testosterone to somebody, if you're considering giving them testosterone, it's going to negatively feedback on the hypothalamus and pituitary, which are going to affect the secretion of LH and FSH that don't just affect testosterone, they also affect sperm production. So really important to remember this whole axis so that you don't give somebody testosterone who's trying to actively get pregnant with a partner, because they will potentially have a big impact on their sperm production, because you're going to shut down some of that FSH that is stimulating Sertoli cells, in addition to stimulating or decreasing stimulation of the testosterone from decreased LH. So that's important to remember the biochemistry and all the pathways. Again, what causes low T? Age. So that's the biggest thing, is age. Certainly there are other things as well, but those are the number one. And that's why any guy over the age of 40 potentially has low T, but also diet, insulin resistance, obesity, those are all factors. So if somebody does have low T, and we'll talk about that in one of the cases, you want to look at lifestyle, absolutely. Stress is a big one. And that's why I reminded you of some of those pathways, because you actually steal away from cholesterol and pregnenolone. Some of the precursors to testosterone get stolen away to make cortisol if you're driving a ton of cortisol production in the adrenal glands, because a guy is so stressed out and in fight or flight mode all the time. So it's important to look at stress and even maybe measure it again through saliva or dried urine, and before just jumping on giving a guy testosterone if you feel like the cause is lifestyle or stress. And then toxins, and that's a whole field that would be great to have another Friday webinar, Tabby, on, is environmental. And you may have already done that on xenoestrogens and environmental exposures.
Yeah, we'd love to do that. That would be great, Myles.
Yeah, so I know the perfect person that can do that for you, but and it's not me, because that's not my expertise, but I do look at it with men, and it's not subtle. It really isn't. So even just talking to guys about, are they heating up food in the microwave in plastic? Do they have, plastic water bottles in their car? All those are estrogenic. And not only are they potentially dangerous for inflammation and cancer and all sorts of things, they actually are estrogenic and will disturb that whole estrogen to testosterone ratio. Raises motor. All right, we'll get back to that. There was a question I can come back to later. So the issue that I alluded to earlier is that testosterone deficiency, it's not only about the symptoms it causes, which are important. We want our patients to feel better and have more sexual fulfillment, but also it affects these other things listed on the slide. And then I'm going to show you some of the evidence behind these things. That low testosterone, clinically low testosterone, meaning under around 300 or 350 nanograms per deciliter, is associated with increased risk for diabetes and metabolic syndrome. And that's bidirectional. And I'm going to show you that in a couple of slides. It affects the brain and cognition. Just like we know estrogen being out of whack in women, especially progesterone and estrogen ratios, affects cognition in women and risk for Alzheimer's, because we know women have higher risk for Alzheimer's than men, but it also affects men's cognition, and that's been proven. Low T contributes to heart disease risk, absolutely proven. Frailty syndrome, sarcopenia, which is low muscle mass, bone loss, inflammation in general. And that's part of the link between testosterone and metabolic syndrome, is low T contributes to aberrant balance of all the cytokines that then contribute to more inflammation. And I know I'm doing kind of a broad overview of all this, but it's a good intro to why it's important to maybe delve deeper into this. So when you look at metabolic syndrome, lots of studies showing that low T is associated with metabolic syndrome, really because of this whole issue with low T affecting insulin and insulin sensitivity. And there's proof that low T decreases insulin sensitivity or increases insulin resistance, which is the hallmark of metabolic syndrome. And giving T, replacing T, and I'm going to show you a really exciting new study that gets to this, actually helps alleviate that and helps improve insulin sensitivity. So these are some of the studies on here. This was a meta-analysis of 20 studies by Brand. Brand is one of the biggest researchers in the field of testosterone deficiency that showed this inverse relationship between total T, free T, and metabolic syndrome. And then these other studies that showed T levels were significantly lower among men with many of these comorbid conditions. And that was a very big study called the Massachusetts Male Aging Study. This Rancho Bernardo study was also a very big study looking at men with all different levels of testosterone and their risk for diabetes, metabolic syndrome, and other conditions, and found, again, very respected study, found that those in the lowest quartile of T had the highest risk for diabetes and metabolic syndrome. And out of the US and Finland, again, these studies have been replicated. So pretty undisputed that true testosterone deficiency, again, under 300, 350, is definitely associated with metabolic syndrome, diabetes issues. So if you're treating a guy for diabetes and metabolic syndrome, why not check his T and make sure that that's not working against you? Because then you're just going to be throwing on medications and adding maybe even insulin to your GLP-1 agonist, when maybe instead of adding the insulin, you could have just normalized his testosterone. This is about that evidence of that bi-directional relationship. So it's really interesting because one causes the other and the other causes the one. Not only is it that low T disturbs insulin and affects insulin sensitivity, but the other way around as well. Again, another reason to check T in your diabetic men, because having diabetes, having metabolic syndrome actually increases the risk of having low T. And a big thing that this slide talks about is inflammation. We know as integrated medicine practitioners, inflammation is behind most of chronic disease in our country. And we know that's increased from the diets and the sleep and the stress and all the things we work on, but it also is made worse by low testosterone. And so really, you want to make sure the hormones are as normalized as possible when you're working on the lifestyle interventions that we talk to patients about, because otherwise you're just working against yourself. You can work on stress and sleep and diet and exercise and connection and purpose and all the things we know affect quality of life. But if their hormones are out of whack, you're really pushing, it's like Sisyphus pushing a rock up a hill. So this is a really interesting study and a slide from that study that really shows how there is this multitude of effect and a link between testosterone deficiency and not only insulin resistance, but also visceral fat accumulation. And we know fat isn't inert. We know it's adipose tissue, which is metabolically active, causes inflammation, increases the bad cytokines and decreases the anti-inflammatory cytokines, contributes, we know adipose tissue contributes to endothelial dysfunction, which it might be why we see testosterone deficiency in heart disease. And we also know that adipose tissue is aromatizing. So you get this vicious cycle where the more low a guy's testosterone is, the more likely he is to build up fat and have metabolic syndrome. And that fat is going to make more testosterone get converted via aromatase enzyme to estrogen. And then it's going to keep up this vicious cycle where then the T he does have that's already kind of low gets converted more to estrogen because he has more fat. That makes him have less T. That T makes more fat. That fat makes more T, gets converted. So you get into this vicious cycle. All right, so then what about giving T? What about the benefits of T? Because it's one thing to know that low testosterone causes certain issues. It's entirely another. You can't just assume then that fixing it fixes all those other problems, right? We don't want to dangerously just assume that. So there are a lot of studies that back up many of these things that can be ameliorated by normalizing testosterone and some of the things that we don't know yet. So sexual issues, by and large, can be helped if you treat someone who has low T with testosterone. And when I say TRT, all the time I'm talking about men who have documented low T, not men who have normal T that you're raising to some high level, men who have documented low T that you're normalizing. And these are studies showing that absolutely normalizing low testosterone helps erectile dysfunction, absolutely proven. And I'm going to kind of breeze through these, but I'm happy to share the slides. Cognitive function, like I mentioned, just like in women, we know imbalance of sex hormones contributes to Alzheimer's and cognitive function. Same with testosterone, and giving testosterone actually helps cognitive function. Again, a really, really big concern among guys these days. There was just a study that showed concern over early cognitive changes in Alzheimer's was rising to as much of a fear as prostate cancer among men presenting at doctors' offices. So a real big issue. This was a study by Bassel looking at androgen supplementation, again, showing that in men from age 34 to 70, they had some of these testing looking at focus and cognition, especially verbal memory and spatial memory, were improved. This is the study that I'm so excited about that just came out. So I would highly recommend you check this out because we all get all metabolic syndrome is such a big thing we deal with a lot because it's an epidemic in this country. It has to do with that, MI, heart attack risk, cardiovascular disease, coronary or cerebrovascular disease, and inflammation, and everything that we talk about. And like I mentioned, we know that low T contributes to metabolic dysfunction and metabolic syndrome, as well as insulin resistance. This study was a very elegant study that just came out a month ago that showed that giving testosterone among patients with diabetes led to remission of their diabetes. So just stop there for a second. You can actually treat diabetes by treating their low T. In this study, over the time, it was all in diabetics with low T. The ones that didn't get T had worsening of their diabetes. The ones that did get T had improvement of their diabetes. So really well done study. This was in the Diabetes Journal, so a very respected journal that just came out, like I said, in June. Further evidence that it's really incumbent upon us to check T levels. So why are we phobic about it? Why are a lot of our colleagues phobic about it? A lot of it's because of media. So what happened was a number of years ago in 2014, there was a lot of testosterone being prescribed, and the press got all excited about it, got the FDA to be all excited about it. And the FDA basically acted based on public opinion that came about from media articles like this one, saying that there's no way that this increase in prescriptions of testosterone could be appropriate. It must be inappropriate. It must just be we're giving guys more T just so they can have better sex and they don't really need it. And it's dangerous and we shouldn't be doing it. So as a result of that, the FDA in 2015 put out a black box warning on testosterone, saying that giving testosterone causes increased risk of MI and CVA, even though they acknowledged that the evidence was very weak for that. As you can see in this box here, on the left hand, the FDA advisory board before the actual FDA recommendation came out said, with regards to cardiovascular disease risks, the panelists confirmed that the evidence linking testosterone therapy to an increased risk of heart attack, stroke, death is inconclusive, yet they still came out with this. So there's a lot of reasons behind this. It was very political. And let me just show you, though, the 4 studies that they cited as the reasoning that there is still a black box warning of increased cardiovascular disease risk on any testosterone product. This includes if you use compounded testosterone that's topical from a compounding pharmacy, they have to include this black box warning, which means it's incumbent upon you, if you're going to use testosterone, to talk to your patients about this and tell them, yes, there was this warning. Yes, there's concern to be a risk. We still don't know for sure, and I'll show you some of the evidence that follows. The evidence leans highly against there being increased risk, and the evidence leans highly in favor of it being protective, but there hasn't been a big randomized controlled trial, so I can't tell you for sure. I can tell you I feel comfortable prescribing it for you because the studies that this was based on are really faulty. And you can look up these 4 studies. These are the only 4 studies that have shown anything negative, and they all have huge faults to them. I do like a whole hour-long lecture on cardiovascular disease and T, so I'm not going to go too much into it. You can look these up on your own. I can just tell you the main 2 are the top 2 here, Basaria and vegan. And you might have heard about them if you were practicing in the teens, like I was, since I've been practicing for decades. But vegan was so bad that has been asked to be retracted by 29 different medical societies. It's had 2 corrections. It included by accident 1,000 women in the study of men and testosterone. It's just a mess of a study. I don't know how it ever got published, and a lot of people don't. Basaria also has it didn't use the right dose of testosterone. It didn't even really mean to measure cardiovascular disease risk. They just went back and looked and found some things that they felt they could report on, but it actually was more about congestive heart failure than CAD. And if you took out congestive heart failure, there was no increase in cardiovascular disease risk. So those are the main 2. The other 2 also have a lot of faults to them. Bottom line is those are 4 studies. There are dozens of studies that show either no increased cardiovascular disease risk from giving testosterone to men who actually have low T, or a benefit. But and this is a great review for you to have in your armamentarium, and you should have some of these things in your armamentarium to be able to be knowledgeable and talking to your patients about these things. This was a big systematic review and meta-analysis of 75 different placebo-controlled randomized controlled trials that included thousands of patients over a mean duration of 34 weeks that showed no evidence of increased risk with testosterone on either composite or single adverse events related to cardiovascular disease. This is a great summary that was published fairly recently that looked at studies that were published after that FDA black box warning was put on. And it basically looked at 23 studies that were published from then till 2018. Marty Miner and Abraham Morgenthaler, Moke Kara, these are leaders in the field. They're really the giants in the field. Miner's at Brown, Morgenthaler's at Harvard, Kara is at Baylor, I believe. Anyway, looked at these studies, 23 different studies, again, showing no study showed adverse cardiac events with TRT, with testosterone replacement therapy, and that in fact, men whose T was normalized, who had low T and were given testosterone, had reduced risk of heart attack and death compared to men whose T levels weren't brought to the normal level. So this is why I feel comfortable prescribing testosterone. There's also, like I mentioned, evidence with inflammation, and giving T normalizes inflammatory profiles. I'll just tell you that the jury is out with regard to CBD officially, because these are all, I just showed you meta-analyses, systematic reviews. There is a big randomized controlled trial underway called the Testosterone Trial, which will be published hopefully in the next year or two, that will answer the question definitively, with enrolling thousands of patients. Let's look at some other concerns that people have around giving testosterone that you'll hear a lot from colleagues and patients. Does it increase BPH? It does not. There's very good evidence that giving testosterone does not worsen BPH. In fact, estrogen is thought to be a more worrisome actor in terms of both BPH and prostate cancer. And so looking at estradiol, looking at progesterone alongside testosterone is really important if you're concerned about prostate health in men. But at the present time, there's no conclusive evidence that giving testosterone increases the risk for either prostate cancer or benign prostatic hyperplasia. There's another study on the prostate cancer issue, and there have been multiple studies. There's literally no question testosterone does not cause prostate cancer. Now, it doesn't mean you don't worry about it. It means you screen for it. And if somebody has prostate cancer, you don't want to give them testosterone because it could potentially worsen it, or at least have a urologist make that decision, because there are times they sometimes do that. I never treat somebody with active prostate cancer with testosterone, but I'm not worried that testosterone caused it. So you're not going to cause it, but you're going to screen for it. Anyone you're at all manipulating hormones on, and make sure that you're finding it if it's there so that you don't worsen it. So this is kind of the fourth study I'm showing you, lots of evidence that it doesn't cause prostate cancer. Sexual symptoms, like I showed you with ED, in addition to ED, other kind of softer sexual symptoms like libido and other issues also are improved if a guy has low T and you help his T. And this is important when we see older guys. 80 is the new 60. We see a lot of patients who are older who want to be sexually active. And it may not be that anyone has checked their T in years and years and years. So just because someone's 65 doesn't mean that they don't want to be sexually active. And like I showed you, age is the #1 risk factor for low T. So something to think about checking, because now I've made you realize you're not going to give them a heart attack if you give T if their T is low. TRT and mood, it can help with moodiness. All right, I want to talk about a patient that, and then I'll get to some of the questions, because I don't want you to think I give everybody just T. And this is a prime example of a guy we see all the time, all of us. Anyone on this presentation sees guys like this guy. He's young, he's only 33, and he has erection problems and lower libido. And he's otherwise pretty healthy. He lives with his spouse, doesn't have any kids, is stressed out beyond belief. I have been in LA for 20 years. So this is an LA patient who was in the entertainment industry, which means you're always working. You never know who you see at a party, if you're going to need to get a job from them next or hire them next, so you're never off. He exercises, he works out with weights and does cardio, so he's fit, he's not overweight. You see his blood pressure is fine, his BMI is fine, so it's not an obesity issue, it's not a metabolic syndrome issue, it's a stressed out guy who's too young to really probably have issues with sexual problems other than he's so stressed out. And when you check his hormones, his T is kind of low. Like I said, bottom is 300 to 350, and it should be up to 900. So this is pretty low. This shows you some of the labs I do check. You check estradiol. You want to check sex hormone binding globulin, so you can get what's called a calculated free testosterone, which will come automatically when you order the sex hormone binding globulin, because the active testosterone is what's either bioavailable or free testosterone. Important, I like to check DHEA sulfite, especially in a guy who's stressed out, because that comes from the adrenal gland and is responsible for libido. You want to check a PSA in case you're thinking of testosterone, and check a hematocrit because giving testosterone can raise hematocrit. Check chemistries again for all the blood sugar metabolic syndrome issues I brought up. Check his pituitary function with LH and prolactin and estradiol. So basically, he had low DHEA because he was so stressed out, and his T was lower than you would expect for his age. No, did I give him T? No, I'm not going to jump and give a 33-year-old guy T who I know has lifestyle issues he can address to help his T. And then if we do those things and it doesn't get better, maybe we would do it, maybe not. So with him, you talk about things. And again, you're seeing guys like Alan all the time in your practice. And he wants Cialis, or he wants, tadalafil, which is generic Cialis, or he wants Viagra. And you could certainly give him that. But you could also say, I bet you wouldn't need it if we got your T a little bit better and your DHEA a little bit better. And we can do that with you doing a little bit of work. Are you willing to do that? And if you've ever heard me talk about men's health, you do one thing at a time. So we don't do all these things on here. You pick one, maybe two things at the most. These are guys, so you don't give them a lot of things to do. So you talk about, guess what? Cortisol comes from the same roots as what makes testosterone. And if you're stressed out, number one, that root, from way back at cholesterol is getting shunted over to make cortisol and not testosterone. Number two, your primal self, evolutionarily feeling stressed, is telling the brain, whoa, we can't be thinking about reproduction. We need to survive. So let's not make testosterone. Just like women stop menstruating when they're stressed, men stop making testosterone when they're stressed. So you're not going to have your normal libido until you manage your stress. So let's look at ways to do that. That could be meditation, mindfulness, breath work. Breath work is so trendy these days with the millennials and the post-millennials. So I've kind of gone away from even talking about mindfulness and talking about breath work. It seems to be a big buzzword these days. Look at sleep and how sleep, we know that low sleep absolutely lowers testosterone. Studies show, there was one study, I think I breezed by it, that guys who got 5 hours of sleep lower their T within a week if they only got 5 hours of sleep a night. You could even, if you want proof, you can measure his cortisol. So some people use, like I said, a saliva ASI, an adrenal stress index, where you check it 4 times in a day, or you could do a dried urine test, or you could do serum, but it's a little tougher to time out the serum. So those are all things to look at to kind of give him some tools that are listed here. You can work on the stress management, maybe try a little DHEA as a supplement, maybe try an adaptogen that helps his adrenal gland not be as reactive to how stressed he is. I love ashwagandha for guys because it's a great adaptogen, and it actually does help with even sperm health, and doesn't make guys tired. It's just it's like holy basil works similarly. It just helps the body feel a little less edgy without making them tired. And if sleep's an issue, something like L-theanine, again, not all at once. I'll do 1 or 2 things, but this is all really, you will all have your different ideas of what to give a guy like this. But the primary point is you don't just jump to the testosterone. As much as you can tell, I do testosterone quite a bit. You first look at the lifestyle issues to see if you really need the testosterone. And with him, his T, this is a real patient, came up for 486. Remember, it was 356. This is just with adding in 1 or 2 things at a time. And by 3 months, we got it into 486, and his DHEA, this was on DHEA supplementation, 50 milligrams a day, went from 107 to 324. And I didn't write on here, but he felt a lot better. Didn't need T, felt a million times better. Libido was normalized, or at least a lot more what he would expect being in a long-term relationship. So again, an example of you don't always need T. So these are some of the non-testosterone options to consider. Exercise, he was already exercising, but more resistance training helps build muscle mass. More muscle mass helps make more testosterone. Fat loss, we talked about that cycle of adipose tissue causing aromatization, which lowers T and gets in that vicious cycle. Cortisol, I tell guys, cortisol is anti-T for all the reasons I already discussed. Sleep is a big issue. I just mentioned there was that article, it was in JAMA, that showed a week of low sleep caused decreased testosterone. And look at meds as well. One thing I haven't mentioned yet, especially narcotics. Opioids absolutely lower testosterone, and other meds as well. All right, I'm going to stop there. I'll just tell you that if you want to use testosterone, we can do that on another webinar or another time to go into the details of how to use testosterone. These are the main guidelines to look at. to protect yourselves. You want to go fairly closely to the guidelines. They're very easy to read and go by, but I'm happy to another time share with you some of the details. I just want to make sure we leave some time for questions here. Okay, so one person asked, books I recommend for raising boys, any culturally sensitive ones? I'm open to other people answering as well. I mean, the one I mentioned by Peggy Orenstein is a great one. I need to go like look on my shelf. There's one that's like, there's the book for girls. It's all about the girl's body that's put out by American Girl. And there's an equivalent one for boys that I can't remember the name of, but we could maybe send that out at another time. Anybody else have culturally sensitive ones? Type them in there or put them in the chat for everybody if you know some good.
Yeah, if you could put them in the chat, that'd be great.
That would be awesome. And someone asked, do you check fasting more? Oh, good question. Okay. When do you check fasting, morning, and total free, all that? Okay. Yes. So traditionally, we always say you have to check in the morning because that's what all the guidelines go by. It turns out that older guys, like over 40, don't have much diurnal variation in testosterone. So it really doesn't matter if they're over 40 when you check it. But if they're under 40, absolutely you should check it in the morning because there is diurnal variation. It'll be highest in the morning, and that's when you should check, because otherwise, if you check it too late in the day, you'll find the T is low when really it might not be that low and they don't really need to treat it. In terms of, and I do check free testosterone and bioavailable by checking the sex hormone binding globulin. So if you have the sex hormone binding globulin, the total T, and the albumin, you can calculate bioavailable and free testosterone. And it's very important to do that because somebody might have classic symptoms of low T and you check his total and it's like 400 and you think, yeah, he's fine. But really he has, for some reason, high sex hormone binding globulin and his available or free T is really low, and he would benefit from some interventions, whether lifestyle or hormone replacement. Let's see, other open questions. Ways to increase T without, I think I mentioned those. The other one is removal of toxins. Like I said, really looking at, especially plastics, phthalates and BPA are very hormonally active and absolutely affected. And then the other big thing is DNA. You know, I mean, that's a whole talk about doing DNA testing. We think about looking at women's metabolic, especially detoxification pathways, when we're worried about breast cancer risk from how they detoxify estrogen. And for men, it's the same thing. We're not as worried about breast cancer risk, but depending on their SNPs and their genes, they may not convert testosterone effectively to DHT, dihydrotestosterone, and that may be what drives libido. And they may not clear it out. They may over aromatize. For example, I have this gene where I convert all mine to estrogen really quickly. So I tried testosterone once and I just felt awful and I got doughy and I hated how I felt. And then I did my genetics and I found I was just turning it all to estrogen. So there are other things you can do to test in terms of that, and that will affect how you would treat a guy. Is it bidirectional? Yeah, I think I addressed that. Treating diabetes. Does treating diabetes, inflammation, and obesity help testosterone levels? Treating obesity will, in that you'll decrease adipose tissue, which will decrease that aromatization that's happening a lot. I don't know that treating diabetes would normalize testosterone. It's a good question. I'm sure it's been looked at. I can't remember if I've seen a study about that. But yeah, addressing inflammation, yeah, you're going to help normalize testosterone because the same interventions that help normalize inflammation are going to help normalize the entire hormonal system.
Myles, I have a question.
Yes.
Just around, like, once you do land on something that's working, how often do you retest? How often do you, when do you come back and say, okay, let's not do it anymore? Or do you just kind of indefinitely leave people on it? Like,
no, good question. Good question. Yeah, I always check at 6 weeks for sure. Just, no matter what intervention, whether it's a lifestyle, natural, or hormonal, to see where things are. And then oftentimes if I'm giving testosterone therapy, if they're making other changes after 6 months, I won't take it off before 6 months because you're usually not going to have a long-term benefit. But if in that 6 months, they've done some of these other things that could help, like work on sleep or stress or decrease alcohol or decrease their fat mass, then you could try tapering off the testosterone to re-challenge them and see. Other guys that aren't really doing that, and let's face it, a lot of patients just are like, just give me the drug and I'm good. I'll leave them on it for just like you leave people on thyroid therapy. I think, but then they get monitored every 6 months and they will not get a refill without refilling it. And that's important just to protect yourself and them that you monitor it.
Great, thank you. Any other questions? Oh, great. So thanks for posting, Rashida, put the American Girl book in, the link to that.
Great. Yeah, that's it. Thank you. Yeah, that's a really good one. I wish I had more culturally sensitive ones to offer. I need to bulk up on my knowledge of that. Last quick question, zinc and ginseng. So yeah, I mean, I didn't talk a lot about herbs. I have a slide on that. There aren't a lot of herbs and natural supplements that raise T. There are a lot that help with libido. Every culture has a libido herb, right? Chinese medicine has ginseng, Ayurveda has tribulus, and Native American, Latin American have maca root. None of those raise T per se. I've never seen studies that ginseng raises T, but it does help libido. Zinc can raise T just a little bit because it blocks that aromatase enzyme. Fenugreek maybe can raise it a little bit. And one other thing called Shilajit, Shilajit, which is from the Himalaya mountains. It's like this mossy thing, and there's actually good science that it raises T, but it's kind of hard to find and hard to palate. So for the most part, it's lifestyle stuff. There's not a lot of natural supplements that actually raise T.
Great.
Thanks, everybody.
So maybe can you share your screen, Myles, and I'll share mine.
Yeah.
Okay, can you all see my screen? All right, so first of all, I just want to thank you, Myles, for coming on. This was such a great presentation and so much great information. And I want to invite you all to get Myles' book, Optimal Men's Health, Your Guide to Being Healthy in Order to Win, which was released in February. So I'm sure all those book signings that you were probably looking to do aren't happening. So maybe we could do one for you that's like virtual or something. But it's a great book. It's a great resource. And just really thankful that you came on today and helped us out with this topic. It'd be great to do some more in the future.
Sure.
And so I just want to invite you all to join us for our annual conference, which is coming up in October. It will be virtual this year, and it is a really great price for members. It's only $150 for 16 CME, and we have an amazing lineup of folks. We are really looking at the topic of racism in our integrative health space and in the different areas of specialties that will be being talked about. It's going to be a really exciting lineup. So I invite you all to come since it's virtual. We can all log in and be part of that. And then continue coming to these free wellness webinars and our monthly town hall meetings. We have Monday meditations, all with folks in the integrative field, just to keep us all together during these times where we can't physically be doing that. And learn more about our fellowship program. Dr. Spar is one of the fellowship faculty. So if you want to learn more about that, we welcome that as well. So stay connected, everyone. And today's webinar got live streamed to YouTube for some reason. Facebook live stream wasn't working, but it was live streamed there. And you can find it on our website and on YouTube afterwards, just the recordings. So we hope to see you all next week. Thanks again, Dr. Spar.
You're welcome. Thank you. Bye, everybody.